Research Spotlight: Tube ileostomy as an alternative to loop ileostomy for the complete diversion of intestinal content. Introduction. Diverting ileostomies are commonly performed to prevent morbidity and mortality caused by colorectal anastomotic leakage. The first account of surgical fecal diversion dates back to the 18th century. To defunction, a distal anastomosis, tube ileostomy has been described, with the intention of performing the same function as a loop ileostomy but avoiding a second operation to reverse it. Nakiappan, S. et al., 2015. A tube ileostomy prevents fecal passage across the anastomosis for a limited period. The choice to create a stoma for fecal diversion during an emergency laparotomy for intestinal perforation and obstruction is challenging for surgeons. There are additional risks associated with creating a diverting stoma, such as stomal retraction, prolapse, or necrosis, para-ileostomy infection, abscess and fistula, intestinal blockage, skin irritability, excoriation, mucosal ulceration. The need for frequent replacement of the costly ileostomy appliance due to leakage caused by the loss of the seal imposes a significant financial burden, particularly in developing countries. The need for a second surgery to close the stoma adds to the financial burden and unnecessary delays. Pottle, V. et al. 2012. A temporary defunctioning stoma is effective for decreasing anastomotic leakage after low anterior resection for rectal cancer and also for primary left-sided resection anastomosis for carcinoma of the left colon. The construction of stoma is protective to anastomosis, but the physical and psychological morbidity created by this procedure must be considered. Stoma-related complications affect up to 30% of patients, such as leakage around the appliance, skin rash and excoriation, high output, peristomal hernia, retraction and prolapse, but its complication including wound infection, anastomotic bleeding and ileus occur in 6.1% to 20% of patients. Liu, L. et al., 2016. According to findings from recent research, ileostomy reversal is related to a mortality rate of up to 0.6% and a morbidity rate of up to 32%. Hanning, D. et al. 2011 and Sharma, A. et al., 2013. To defunction, a distal anastomosis, tube ileostomy, has been described, with the intention of performing the same function as a loop ileostomy but avoiding a second operation to reverse it. The former has been used more extensively. The procedure of tube ileostomy is based on the concept of the currently well-accepted feeding jejunostomy. Tube ileostomy is not a new surgical procedure. Incomplete fecal diversion has remained a problem precluding widespread adaptation of the technique. Recent improvements in technique may have overcome these problems. The purpose of this study is to assess the feasibility and outcome of a proximal tube ileostomy in place of a defunctioning proximal loop ileostomy in patients treated by primary repair and/or resection anastomosis of the small bowel or resection anastomosis for carcinoma colon and upper rectum. Nakiappan, S. et al. 2015. In order to address the issues associated with incomplete fecal diversion, this research aimed to develop a novel approach. Rationale of research. The conventional loop ileostomy is linked to a decline in the patient's overall quality of life as well as their physical and psychological health. Significant morbidities are linked to malfunctioning loop ileostomies and their subsequent reversal. The repeated need for expensive ileostomy equipment and the requirement for a second surgery and the non-prioritization of stoma closure due to a high case volume all contribute to higher costs and a longer hospital stay. Case series and non-randomized studies in recent years demonstrated that tube ileostomy is feasible and there are no statistically significant differences in anastomotic leak rates compared to loop ileostomy. Nakiappan et al., 2015. The main benefit of tube ileostomy is that it provides complete diversion of intestinal content with avoidance of stoma-related morbidities and no requirement of second surgery. There is a noticeable lack of clinical trials comparing the two techniques, and no documented case series or case studies on the use of tube ileostomy from Bangladesh. This highlights the urgent need for prospective clinical research in this area. The present study is designed to address this gap and may assist surgeons in evaluating whether tube ileostomy could be a suitable option in the management of patients undergoing elective distal colorectal resections or emergency distal bowel surgeries in our clinical setting. Research question. Is there any significant difference in immediate outcome between tube ileostomy and conventional loop ileostomy? Research hypothesis. Completely diverted tube ileostomy is superior to conventional loop ileostomy for reasons such as lack of need for reversal surgery and fewer complications. Objective of study. General objective: to evaluate the outcome of tube ileostomy compared to conventional loop ileostomy as a diversion procedure. Specific objective: to observe the achievement of complete fecal diversion between loop and tube ileostomy. To assess and compare the outcome between two groups in terms of following parameters: day of stoma functioning, daily stoma output of the study subject, tube removal, stoma reversal time of the study subject, length of hospital stay, tube ileostomy, loop ileostomy related complication. Review of literature. Several studies have compared tube ileostomy with conventional loop ileostomy for fecal diversion. Balut et al. 2022, prospectively studied 40 patients, showing fewer complications in tube ileostomy, 15%, versus loop ileostomy, 65%, p equals 0.002, and a shorter median stoma duration, 21 versus 27 days, p less than 0.001. Patel et al. 2012, reported reduced morbidity with tube ileostomy in 60 patients with ileal perforations. Chowdhury et al. 2010, followed 30 patients undergoing distal colorectal surgery with tube ileostomy, noting low complication rates, good patient satisfaction, and no need for a second surgery. Atala et al. 2020, demonstrated that a removable strip tube ileostomy achieved complete diversion in all 50 patients, with spontaneous fistula closure post-removal. Zhou et al. 2014, introduced a completely diverted tube ileostomy, CDTI, for low colorectal anastomosis, showing safety and effectiveness comparable to loop ileostomy. Suryavanshi et al. 2016, retrospectively confirmed tube ileostomy as a safe diversion method with minimal stoma-related morbidity. Background: defunctioning ileostomy, D, prevents anastomotic leakage, AL, a serious postoperative complication, particularly after low anterior resections. While stomas reduce sepsis risk, they carry their own complications and affect quality of life. Rabari et al. 2010, Coletta et al. 2022, Lin et al. 2011. Loop ileostomy, first described by Turnbull and Weekly, 1966, involves exteriorizing an intestinal loop with a supporting rod to prevent retraction, followed by stoma closure later. Variants include skin bridge loop ileostomy, Pace et al. 2014, umbilical ileostomy, Hada et al. 2018, and transecal ileostomy, Simpson and Shrivastava, 1975. Tube, cannula ileostomy, involves inserting a tube or cannula into the distal ileum, secured with purse string sutures. The tube is deflated, clamped, and removed after 2 to 3 weeks, creating a controlled fistula and avoiding a formal stoma. Zhou et al. 2014, Chowdhury et al. 2010, Sheng et al. 2016. Materials and methods. Study design. Quasi-experimental study. Place of study: Chittagong Medical College Hospital, Chattogram. Study population: patients undergoing emergency or elective colorectal surgery requiring a defunctioning stoma. Sample size: using Sharon and Biswas, 2013, formula, with expected complication rates of 15%, tube ileostomy, and 65%, loop ileostomy, 28 patients per group were required after adjusting for 10% dropout. Sampling method: convenient sampling. Inclusion criteria: patients aged 18 to 70 years undergoing surgery requiring a defunctioning stoma. Exclusion criteria: uncontrolled DM, typhoid perforation, critically ill, psychiatric illness, intestinal motility disorders, neurological deficit, or unwillingness to participate. Procedure: tube ileostomy was performed using a reinforced 7.5 mm endotracheal tube inserted 20 cm proximal to the ileocecal valve, secured with double purse string sutures. A rubber strip occluded the distal ileum to achieve complete diversion. Postoperatively, the tube was monitored for patency, flushed as needed, and removed after 3 weeks to form a controlled enterocutaneous fistula. Complete diversion was confirmed if no defecation occurred before removal of the strip. Drain sites were managed with dressings, and spontaneous wound closure occurred in 4 to 9 days. Data collection: pre-designed case record form. Data analysis: data were entered in SPSS v25. Continuous variables were expressed as mean plus or minus SD, categorical variables as frequency and percentage. Student t-test and chi-square test were used for group comparisons, with p less than 0.05 considered significant. Ethical considerations. Ethical clearance was obtained from the Chittagong Medical College Ethical Review Committee. Written informed consent was obtained in Bengali, participation was voluntary, and confidentiality was maintained. Results. Table 1. Age distribution. The mean age was slightly lower in the tube ileostomy group, 37.57 plus or minus 13.73, compared to the loop ileostomy group, 41.92 plus or minus 17.06, with no statistically significant difference. P equals 0.693. Table 2. Sex distribution. Gender distribution was similar between groups, male, 60.7% vs 57.1%, P equals 0.786, indicating comparability of the groups. Table 3. Emergency procedures. Tube ileostomy was performed more frequently in emergency cases than loop ileostomy, 46.4% vs 28.6%, P equals 0.025. Perforation sites and acute intestinal obstruction were similar between groups. Table 4. Routine procedures. Loop ileostomy was more commonly used for left colon carcinoma, P equals 0.001 to 0.036, whereas tube ileostomy was more frequent in rectal surgeries, P equals 0.001 to 0.019. Table 5. Day of stoma functioning. Tube ileostomy functioned earlier, with 85.7% of patients showing stoma output on the day of surgery or first pod, compared to 50% of loop ileostomy patients by the second-third pod. P equals 0.001. Table 6. Daily output. Mean daily output was significantly lower in the tube ileostomy group, 482.14 plus or minus 81.89 milliliters, than in the loop ileostomy group, 746.42 plus or minus 138.06 milliliters, P equals 0.001. Table 7. Tube, loop removal time. Tube ileostomy was removed significantly earlier, 21.03 plus or minus 0.33 days, compared to loop ileostomy reversal, 56.53 plus or minus 6.47 days. Table 8. Complications. Overall complications were lower in tube ileostomy, 32.1% vs 64.3%, P equals 0.001. Loop ileostomy had more skin excoriation, 60.7%, postoperative ileus, 21.4%, and other stoma-related complications, prolapse, retraction, necrosis, mucocutaneous separation. Tube ileostomy complications were mainly peritubal leak, 28.5%, and tube blockage, 21.4%. Table 9. Length of hospital stay. Index admission duration was similar, 27.00 vs 27.56 days, P equals 0.891. Loop ileostomy required a second admission for stoma closure, mean 11.26 plus or minus 4.36 days, which tube ileostomy avoided. Overall interpretation. Tube ileostomy shows earlier stoma function, lower daily output, shorter stoma duration, fewer overall complications, and avoids a second hospital admission, making it a safe and effective alternative to loop ileostomy. Tube ileostomy is an effective alternative to loop ileostomy, protecting distal anastomosis while reducing stoma-related complications and avoiding morbidity from stoma takedown. Patel et al. 2012. In this study, age and sex distribution were comparable between the two groups, with no significant differences, P equals 0.693 for age, P equals 0.786 for sex. Consistent with previous studies. Adnan et al. Patel et al. Balut et al. Joe et al. Tube ileostomy showed earlier stoma function, with 85.7% of patients having output by first pod, compared to loop ileostomy where most patients began stoma function on second-third pod. P equals 0.001, similar to Suryavanshi et al. 2016. Daily output was significantly lower in the tube ileostomy group, 482.14 plus or minus 81.89 milliliters versus 746.42 plus or minus 138.06 milliliters, P equals 0.001, aligning with Balut and Adala, 2022. Tube removal occurred earlier, 21.03 plus or minus 0.33 days versus 56.53 plus or minus 6.47 days for loop ileostomy. Overall complications were significantly lower in tube ileostomy, 32.1% versus 64.3%. Loop ileostomy had more skin excoriation, 60.7%, postoperative ileus, 21.4%, and other stoma-related complications, whereas tube ileostomy complications were mainly peritubal leak, 28.5%, and tube blockage, 21.4%. These findings are supported by previous studies, Patel et al., Balut et al., Malik et al., Rondelli et al. Conclusion: this study demonstrated that tube ileostomy was alternate diversion procedure with few complications and was easy to construct and manage as compared to loop ileostomy. It effectively diverts the bowel contents and avoids the need for a second surgery and its related complications. Limitation of study: sample size was small and thus results cannot be generalized on the basis of this study. Long-term follow-up was not possible to take. Single center. Different procedure was done by different level surgeon. Recommendation: from the findings of this study we recommend to carry out large multicentric prospective study.